Good evening. Thank you for joining us today. I do apologize about the delay, but I hope that this next few minutes to half an hour would be quite useful for you in terms of the information that we are able to provide and discuss any questions as well. Once again, my apologies. So, I'd like to just introduce about our clinic. So Care Fertility is an international unit primarily based in the UK, but so as you can see on this slide, we have quite a few clinics covering different parts of England and Northern Ireland, and there's also branches in the United States and Spain. Now, the first step in any fertility treatment is to get the right diagnosis. And to get the right diagnosis, we do need detailed information from you and also investigations. And these investigations include things like a blood test called AMH for the female partner to check how their egg reserve is, an ultrasound, which helps us to identify any problems in the uterus or ovaries, and of course, a semen analysis for male partners. Once these investigations are completed, then we can really discuss in detail what these investigation results mean and also about the potential fertility treatment options in detail when you have your consultation with any of my consultant colleagues. Now, this picture depicts what happens in the IVF process, and I like how this picture displays it because it displays everything so neatly and compactly and succinctly in one image as to what happens throughout the IVF journey. So we'll walk through different stages in detail. First, we'll start off with what happens before we retrieve the eggs from the ovaries. Now, in a natural menstrual cycle, if someone has regular cycles, a person will normally produce 1 egg a month. Sometimes, very rarely, you can have 2 eggs or more, which is why you can sometimes have non-identical twins in a natural conception, but generally it's 1 egg being released. And in an IVF process, what we do is we give you injections to stimulate your ovaries, and these injections are designed to be subcutaneous injections. So injections are designed to be delivered through a thin needle and therefore designed to be self-administered. Once these injections are given over a couple of days, then we need to see how the ovaries are responding to these medications. And the way we do that is by performing ultrasound scans. And these are to look at how the ovaries are responding and also to look at the lining of the womb. We then perform an egg retrieval, which is performed under sedation, generally. We might use a combination of things like local numbing injections and so forth. And then it involves passing a needle through the vagina into the ovaries to get the eggs. And the reason we do this through the transvaginal route, as it's called, is because the ovaries are right next to the skin of the vagina. If you see this picture here, this is the skin of the vagina and the ovary is right next to it. So there's very little intervening tissue between the vagina and the ovary, and allows us to perform this procedure in the safest way possible. On the day of the egg retrieval, the partner provides a sperm sample. The sperm is then analyzed under the microscope. And you might have either IVF or ICSI. These are terms you might have heard. IVF is in vitro fertilization. Basically, we let the sperm bind to the eggs in a dish. And ICSI is where we take the sperm and inject into the eggs. And our team will just play a video on ICSI for you now. So this is the egg in the center, and on the right hand side is a needle and the sperm inside. And basically there is a entry of the needle into the egg, and then the sperm is injected into the egg. And the aim of this process is to help with fertilization. Next, once the eggs are fertilized with either IVF or ICSI, the next day we hope to see a single cell fertilized egg. Now, it's important to make it clear that not all eggs, unfortunately, will form embryos. On average, 2/3 of eggs are mature and 2/3 of mature eggs fertilized to form embryos. And then these embryos go through a series of cell division. This is the embryo at the 1-cell stage, and then you have the 2 cells, and then it divides into multiple cells and then forms a lovely blastocyst stage embryo on day 5. My colleague will just play now a Care Maps video in which we'll show you how the different stages of embryo development happen. So this picture, this video is a time-lapse video, so multiple pictures taken over time points, consolidated into a single video, and you can see the embryo dividing into different cells, and the cells then starting to organize themselves. And once they have completed this organization, they split into 2 populations of cells, one which forms the future placenta, and the inner group of cells called the inner cell mass, which potentially forms the future embryo. And then the embryo will start to hatch out of its shell and ready for implantation. This video you saw is called a time-lapse imaging video. Essentially, it is taking lots of different pictures of the embryo and then putting them all together to generate a compressed timeline of the video. Now, the time-lapse imaging, in addition to providing such detailed information about embryo development, also allows us to measure each of these timings of these cell divisions accurately. So we can know exactly when an embryo goes from 1 cell to 2 cell, 2 cell to 3 cell, and 3 cell to 4 cell, and so forth. And then we can take all of these time points, the regularity of these time points of division, the evenness of these cells, and this gives us hundreds of data points per embryo, which is then fed into an artificial intelligence algorithm, which then predicts the chance of embryo implantation using data from thousands of different embryos which have known implantation or not before. And this is the Care Maps artificial intelligence algorithm, which has been awarded the UK IT Industry Awards. I think of this as providing like a developmental milestone picture of the embryos, how the embryo is going through different stages. The algorithm doesn't make the embryos better, it helps us choose between embryos. So the 3 benefits of this: one is it helps us choose between embryos if you have more than one embryo. It helps us give you a more individualized chances of success once the embryo is transferred. And also it can help us look at where things may not have gone right for you should you unfortunately have an unsuccessful cycle. Now, the aim is to transfer one embryo because that's the safest way to reach a pregnancy. And if you have any other embryos, we can freeze those embryos for your future use. The next stage is the embryo transfer, where we transfer an embryo into the uterus. And this is done by passing a speculum and a plastic catheter through the neck of the cervix into the uterus. At this stage, I'd just like to discuss about what pre-implantation genetic testing is, that is called PGTA. One of the reasons why not all of the embryos go on to result in a pregnancy is that a proportion of the embryos can be genetically abnormal. We'll now play the PGT video for you where I can explain what the process involves. So in the previous video, we saw the embryo splitting into 2 populations of cells. One formed the future placenta and one forming the future embryo. And the cells forming this placenta, that's called the trophectoderm, can be biopsied and sent to the lab. Because these are cells forming the future placenta, not the embryo, the procedure does not affect the embryo. There is no difference in the risk of preterm birth, low birth weight, or anything like that with performing this embryo biopsy. And these biopsied cells can then be assessed to see if they're genetically normal or not. Artificial insemination, also known as IUI or intrauterine insemination, is a procedure where the sperm from your partner, or if you're using sperm donor, will be prepared and used for insemination. So it's similar to, the procedure itself is similar to an embryo transfer. It involves passing a speculum and then a catheter through the cervix. It is a very good treatment option for patients using a sperm donor, because it's frozen sperm, we time the insemination to the date of ovulation. And if you are having artificial insemination, one of the options we'll discuss in terms of investigations, in addition to the other tests we discussed before, is to do a test for your fallopian tubes. And that can be done by different methods called a dye test, which we can discuss if that is appropriate for you. For same-sex female couples, shared motherhood allows both partners to participate in their family building. In shared motherhood, one partner in a same-sex relationship provides the eggs and is genetically the mother of the child. The other partner carries the pregnancy and therefore is the birth mother. And this allows both partners to take part. We have our own sperm and egg banks, and if you need sperm donation, donor sperm or donor eggs, we have a dedicated donation team who will be able to provide you options of donors from different sperm banks. In addition to anonymous egg donation, which is what the egg bank provides, we also have the option of known donation, where if you would like someone known to you to donate the eggs to your treatment cycle, we can facilitate that. And we also have winner of the National Surrogacy Awards. We are having a dedicated surrogacy team who can support you with the surrogacy process. Surrogacy can be quite complex because there are multiple forms to be completed. There are considerations from the legal aspects, which our surrogacy team will signpost you to from the legal side of things as to what you need to have from the solicitors and so forth. In gestational surrogacy, there are two types of surrogacy. The more common type of surrogacy is gestational surrogacy, where it's a combination of donor eggs, where the baby is not related to the surrogate mother. So in other words, the person carrying the pregnancy is not genetically the mother of the child. In traditional surrogacy, the surrogate also provides the eggs, and therefore the surrogate is the genetic mother of the child. And so there are different options appropriate for different situations. More often we go for gestational surrogacy because that is the appropriate management. We have counseling support available at our services, and our team is there. We have different specialized teams specializing in different aspects of fertility treatment who can support you. And these are different ways we provide support listed in this, like the inquiry team, the Care Resource Hub, which is online. We also have the SALV app, and we have counseling services, and obviously the Care Pals team. Thank you for your patient listening. I'll just have a question about the message. So I'll just have a look through the questions. Yes. So there was a question about if we don't get sufficient eggs in a particular month, then next month would the response be any different? Now, there is cycle-to-cycle variation in ovarian response. We know that even the same person in the same type of medication, same dose, you can have quite different number of eggs from month to month. The chances of having a different outcomes depend also on some of the test results, like preceding your cycle, for example. And that's one of the reasons why we recommend tests like the AMH to check your egg reserve and the scan before any treatment cycle, because if there is a ovarian response which is quite different than what is expected from the AMH, then that is indicating that is more likely that this is a natural variation, more likely to have a better and different response next time. However, if it is the case that the ovarian response is similar to what was predicted with the AMH, then a further cycle is difficult to say how far the outcome might be different. So question about mild IVF. Mild IVF is using a milder dose of stimulation, and that is something we use for women who have a higher egg reserve. So if the AMH levels are higher and you're expecting a high ovarian response, we use a more modest dose of injections to stimulate the ovaries in order to reduce the risk of ovarian hyperstimulation syndrome. Next question about do both of you have to have injections if you're a same-sex couple? Not necessarily, because it depends on, I presume the question is about same-sex female couples. So not necessarily, because it depends on what type of treatment you are going for. If you're going for artificial insemination or IVF with donor sperm, then only one partner needs to have the treatment. But if you're having shared motherhood, then both of you will be having medication, usually timed so that the egg retrieval is happening at the same time that the other person is starting the progesterone treatment. So next question, how can we extract sperm from someone with a low sperm count? Now, if there is sperm in the ejaculate, that is when a partner produces a sperm sample, then we can use that sperm for fertility treatment through ICSI. And for ICSI, we don't need a lot of sperm. So definition of a normal sperm count is more than 15-16 million. So even if your sperm count is like 1 million, and even only if 10% of them are moving, that is still sufficient sperm for us to do ICSI. If someone has no sperm in the ejaculate, then we will recommend surgical sperm retrieval. And there are different types of surgical sperm retrieval, and the different types, essentially the testis is like, if you think of it as the industry producing the sperm, you have a structure called epididymis, which is like the warehouse storing the sperm. And then you have the pathways or the roads coming out where the sperm comes out. Sorry if it's a bit graphic. But essentially, if there's a block, there will still be sperm produced and stored. And then we can get sperm from this epididymis, which is like the warehouse of where the sperm is stored. Whereas if there's no block, it's also called non-obstructive azoospermia, then it is better to get sperm directly from the testis. So it very much depends on what the reason of the low sperm count, reason of the absence of sperm in the ejaculate is. Pregnancy pause time in respect of diminishing egg reserves. No, a pregnancy doesn't change the rate of egg reserve decline. So ovaries are like a vault containing lots of eggs, and the vault releases a certain proportion of eggs. It is a certain proportion, not a certain number. So someone with a high egg reserve will release more eggs from the vault a month, whereas someone with a low egg reserve will release less eggs from the vault a month. So it's a proportion, not an absolute number. And this initial release of eggs from the ovarian reserve is not influenced by gonadotrophins, that is the hormone levels. In fact, the eggs are declining in the ovary even from birth, even before puberty, even before someone's first period. And for instance, taking like the combined pill for contraception doesn't halt the rate of how the eggs are released from the ovary. So they are unfortunately completely hormonally independent. And that's one of the reasons why we unfortunately don't have any means or methods right now to change how someone's egg reserve changes with time. I've been asked about what is the upper age limit for treatment with own eggs. The success rates of fertility treatment do decline with time. And what is an acceptable number for one person may not be an acceptable number for another person. As a unit, we have made the question also comes, at what stage is it ethically appropriate to proceed to treatment which has unfortunately very low chance of success? So as a unit, generally we discourage treatment, and if someone is above their 46th birthday with their own eggs, it's because unfortunately the success rates are quite low at that stage. Been asked about, does age affect male fertility? Not to the same extent that it affects female fertility, but it does affect male fertility. And that is one of the reasons why sperm donors have to be 45 or less, age 45 or less. What can a man do to help with sperm quality? There are different things. First, let's look at things from a lifestyle side of things. Healthy, balanced diet, plenty of fruits and vegetables, less ultra-processed food. There's just been a recent study which came out indicating that more ultra-processed food intake was associated with decline in sperm quality. Now, many of these things can be interrelated. If you're taking lots of ultra-processed food, it's not just the ultra-processed food which causes a problem, but also the fact it is displacing out more nutritious food, and so you're more likely to have nutritional deficiencies. On top of that, you can consider taking a multivitamin. I don't recommend any particular brand. I don't think there's enough data to say one brand is superior to the other. But if you're taking a multivitamin with antioxidants such as vitamin C, at least it can do no harm, and you're sorting of backstopping any sort of mild nutritional deficiencies which can be there. In addition, you can, if you're overweight, I would recommending getting to a normal weight. If you're having a sedentary lifestyle, more active lifestyle, these things can help with sperm quality. Do I have to stop smoking to have treatment? So that's a very good question. I would, if there is one lifestyle aspect which makes the biggest difference to fertility success rates, it's smoking. Smoking essentially halves the odds of success with IVF for women, and close to 30% or more reduction if a male partner is smoking. Even just exposure to passive smoking can affect the success rates for women significantly. In fact, I would say stopping smoking would give greater benefit than any sort of intervention, laboratory technique, or supplementation advice we can give. So smoking is a big thing. If you're having NHS-funded treatment, yes, you will definitely need to stop smoking. If you're having self-funded treatment, we very, very, very strongly encourage to stop smoking because it's very detrimental to your success rates. But at the end of the day, there is a degree of personal freedom and personal responsibility. They both go hand in hand. On average, how many cycles of IVF? It depends. We are actually working on a research project which will help list this in greater sort of potential numbers depending on someone's age and someone's egg reserve. So the two main factors which influence how many cycles of IVF a person would need is age and egg reserve, because age determines what proportion of embryos will be genetically normal, and egg reserve helps influence how many eggs we will get, in turn influences how many embryos you'll have. PGTA improves the implantation chance of an embryo. So PGTA, I would take it as a selection tool. If you think of it as a selection tool, then it makes a lot of sense. So for instance, if you have, let's say, 4 or 5 embryos, by using PGTA, we can narrow down which of those embryos is most likely going to result in a baby. And even it reduces the number of transfers you need. So those are the advantages. It reduces the odds of a miscarriage, particularly for women over 35 or 37. There is a significant reduction there, in particular women over 37. Does it guarantee success? No, unfortunately not, because it is possible that none of the embryos might be genetically normal. So sometimes it's possible that unfortunately all of the embryos in a particular batch of embryos may not be genetically normal. So yes. And even genetically normal embryos, not all of them implant. A greater proportion of them implant, much greater proportion, but not all of them implant and result in a baby. If you're having treatment for the first time, is IVF better than IUI? It depends on your individual factors. If you look at the per cycle success rate, generally IVF will outweigh IUI, generally in most circumstances. But IUI has advantages like it being less invasive, and in certain circumstances, there is more funding available for more cycles of IUI. For instance, in Leeds, if you're a same-sex female couple and neither partner has a child, then you are funded for 6 cycles of IUI, and therefore it would make sense to go for the 6 cycles of IUI, especially if time is on your side. Does age affect? Questions. What's the? Oh, thus I asked about what's the oldest age for same-sex couples before treatment won't work. I'm not sure if it's same-sex female couples or same-sex male couples. I'll answer for both. For same-sex female couples, the success rates depend primarily on the age of the person providing the eggs. And therefore, as we said before, the upper age limit would be someone's 46th birthday. If it's same-sex male couples, there is no hard and fast number, but we need to take into account different factors like sperm quality and so forth. And it's a bit different conversation about those situations. Is there anything we would recommend for someone who has had multiple miscarriages? Yes. So we recommend thyroid screening and antiphospholipid antibody syndrome screening. These are generally investigations which are recommended. And then depending on your particular history, we'll also get a family history, any links running in the family, any family history of recurrent miscarriages. Based on that, we might fine-tune further investigations. And depending on the investigation results, we might advise treatment. For example, if someone has an underactive thyroid, we would recommend thyroid supplementation and so forth. At what point of the cycle do we start medication to stimulate follicles? So what we do is try and get a good cohort of eggs of a uniform growth parameter. And the way we do that is try and start the treatment in the early part of the cycle. And sometimes we may use the combined oral contraceptive pill to get a tighter cohort of eggs so that all the eggs are almost at the same stage of development when they start ovarian stimulation. That is generally. My special interest is actually fertility preservation, and if we actually put together this is outside fertility. My primary focus is on women and men having cancer treatment, having to freeze their eggs or sperm before they have cancer treatment. And we put together a website called cancerfertilityandme.org.uk, which goes through this in more detail. And in those circumstances where time is of the essence, we start medications regardless of where someone is in the menstrual cycle, because every day is important for them to start chemotherapy. And we are one of the centers which started this initially in the north of England. Is there anything we'd recommend for they froze your eggs? Egg freezing. There's been a question about egg freezing. So egg freezing is essentially, it's a risk benefit sort of situation. We have to weigh up the short answer about egg freezing is yes, freezing eggs now will give you a better chance of having treatment success rate with those frozen eggs as compared to using your own fresh eggs in the future. But this makes a couple of assumptions. Assumption number one is that you are going to be waiting that length of time where age will have an impact on your fertility. And generally, age doesn't have an impact on your fertility till your mid-30s. So for instance, if you froze eggs when you were 23 and then you're thinking of fertility treatment when you're 27, 28, it's unlikely there will be a massive difference between fresh eggs and frozen eggs. Whereas there's a different situation for someone freezing eggs at 34, 35 versus using them at 40, 41. That's the difference there. So that the time frame matters. It's not the absolute numbers. It's the difference. It's the actual numbers which matter as well. The second factor is sometimes it's possible you may never need to use those frozen eggs. So that is also another thing to consider. So you might get pregnant naturally, and in which case you may never need those frozen eggs. And this is actually something we discuss quite pragmatically. As I said, my special interest is in egg freezing for men and women women having cancer treatment, and sperm freezing for men having cancer treatment. And this is a conversation we have. We tell them this is a backup. You may never need to use them, but if you froze them, at least you have the option of using them. And it's also important to know that egg freezing doesn't provide a guarantee of success. It gives you a better chance. It improves your odds, but it doesn't give a guarantee. And it obviously means going through all the medications and so forth. Sports. I would advise against high intensity training. And the reason for that is we advise against high intensity training during pregnancy. We advise mild and moderate intensity exercise. And when going through IVF, we would advise you to carry on treat your body as you would during pregnancy. And so while mild and moderate intensity exercise is absolutely fine, I would discourage high intensity exercise, same as I would discourage high intensity exercise for someone who's pregnant. Oh, supplements. So supplements, I would classify as two types of things: core supplements and then optional supplements. The core supplements we recommend all women planning for a pregnancy to take, regardless of whether they're having fertility treatment or planning for a natural pregnancy. This is in UK guidelines. One, we advise them to take folic acid. You should take folic acid 400 micrograms per day. If there are some situations where we advise a higher dose of folic acid 5 milligrams per day, that would include women whose BMI is over 30, women who have diabetes, women who have a family history of what's called neural tube defects. And also there are some rare blood conditions called thalassemias, in which we also advise a higher dose of folic acid. The second supplement is vitamin D, and we recommend all women having fertility treatment, or in fact, even during pregnancy after natural conception, the guidelines are to take vitamin D supplements to reduce the risk of complications in pregnancy, and also reduce chance of rickets, calcium deficiency and bone deficiency for the baby. Not calcium deficiency per se, but more of a bone formation. Apart from this, there are many optional supplements. Now, these optional supplements include things like coenzyme Q10, and these are hypothesized to help with egg quality. It has to be emphasized here that the trials on coenzyme Q10 have been relatively small till date. To show that an intervention makes a difference to chance of having a baby, generally you need trials in their thousands, as in you need 4,000, 5,000 people to be included in a randomized trial. Only then will you be able to say with reasonable certainty whether a particular supplement helps. Unfortunately, till now, most of the supplements haven't been subjected to such sort of large trials. Smaller studies seem to indicate it might help with embryo quality, but we still don't have the large enough studies to say it definitely helps with the live birth rate. So that's one is coenzyme Q10. Other things. So apart from supplements, how can you help with egg quality? Similar to what I said about sperm quality, factors which affect egg quality are the quality of nutrition. So what sort of food you take, balanced diet, plenty of fruits and vegetables, less ultra-processed food. There are a couple of studies on the Mediterranean diet, sort of low carbohydrate, more protein, more plants. When we think about the Mediterranean diet, it is not pizza and pasta. When they say Mediterranean diet in the studies, they mean the classical unprocessed Mediterranean diet, which involves lots of olives, olive oil, different types of fruits, vegetables, not much meat in fact, but there is meat and seafood. Most of the meat is actually seafood and so forth. So that sort of diet is helpful. Also, if you're overweight, trying to get your weight into a normal condition. If you have any medical conditions, trying to optimize those medical conditions as much as possible. This applies to both men and women. When trying to conceive, can you end up reducing sperm count on day of ovulation if you start having sex 3 to 4 days prior to ovulation day? No, it is not. In fact, no. Previously, there was a thought process that having daily sex is counterproductive and sex should be alternate days. There's been a well-designed retrospective study in the US, and they found that people having daily sex were not disadvantaged by any means. So daily sex is similar, even slightly better success rates than alternate day sex. So whether you're having sex daily or alternate days from 3 to 4 days prior to ovulation day, I don't think it's going to make a massive difference for natural conception. I need to specify this is for natural conception. When you're having fertility treatment like artificial insemination or IVF, we need to do what's called sperm preparation because we can't use raw sperm. We have to prepare the sperm to remove out all the dead sperm and so forth. And to do that effectively and efficiently, you need to have 3 to 5 days of abstinence generally. Why is weight an issue? So now there have been a few studies indicating that weight does affect egg quality. Now that's why when we discussed about egg quality, how can we improve, we discussed about weight. So there is data to say that actually the composition of the egg or how the egg's quality is as measured by different parameters like what's in the egg, how's the egg energy production and so forth. These are influenced by weight. So that starts from the egg. So number one. Secondly, you're more likely to have cycles where you're not ovulating. There's a higher weight. And thirdly, there can be issues with the womb lining. The chance of the womb lining implanting, that's called the endometrial receptivity, can be affected. And then you have a risk of miscarriage and so forth. So it's a continuum of things. It's not just one factor. There are multiple factors which are affected. Just like, for example, smoking. Smoking just doesn't affect the eggs. It affects the eggs, it affects the sperm, it affects the fallopian tubes, which is why you have increased risk of ectopic pregnancy, increased risk of miscarriage, and so forth. ovarian hyperstimulation syndrome. So, as we discussed, one of the things we do in an IVF cycle is to stimulate the ovaries to produce multiple eggs. And ovarian hyperstimulation syndrome happens when the ovaries respond more than what we anticipated. Now, you can have either extremes of ovarian response. So when you discuss about ovarian hyperstimulation, we need to discuss what the full spectrum of responses could be. So you could have a normal response, a high response, and a low response. Low response, we don't get enough eggs. Normal response, we get an optimal number of eggs. And high response, we get lots of eggs. And we get lots of eggs, that's called ovarian hyperstimulation syndrome. And there are two types of hyperstimulation syndrome. One is early, other is late. The early hyperstimulation is more predictable. It depends on the number of eggs, so it's more easily preventable. Late hyperstimulation syndrome is not as predictable because it doesn't have a linear correlation with the number of eggs, and so it's more difficult to prevent. If you have been told you're at risk of ovarian hyperstimulation, it will probably be the early type, which is linked to a greater number of eggs. And if that is the case, your ovarian stimulation protocol will be adapted accordingly. I have TPO but not thyroid. Does this impact? So TPO antibodies means you're more likely to develop thyroid issues in the future. If you just generally, again, this is a subject of ongoing active research, but there have been two big studies, one in the UK, one in Europe, which have shown that if the thyroid levels are normal, that's if the TPO antibodies are present, there doesn't appear to be any benefit of intervention, which seems to indicate that probably the antibodies themselves don't have such a major impact. But obviously, this is very much a subject of ongoing research. But as of now, as long as the TPO antibodies, I would take it as more of a marker of you're more likely to develop a thyroid problem in the future. So we need to keep a closer eye on your thyroid levels. Perhaps check your levels once. The UK guidelines suggest if you have antibodies, then check your levels at least once a year. Is DHEA beneficial for equality? It's again a subject of quite a few studies, but unfortunately, you don't have the big quality studies yet. So, in fact, Leeds, we were one of the centers in a multi-center trial looking at DHEA. So what we seem to think is that DHEA seems to help women who are under 38 with a low egg reserve. It seems to help them to a greater degree. Women who are over 38 or in their early 40s with a low egg reserve, we don't have enough data, and that's what we were planning to explore in this randomized trial. Unfortunately, we didn't have enough numbers to say for sure, and the trial had to be terminated early because we were not getting sufficient numbers to enroll into a randomized controlled trial, unfortunately. So at present, the jury is out, but as long as someone doesn't have side effects and understands that the data is a bit limited, I think it is reasonable to consider, but you need to be aware that most of the data is probably for women who are younger with the low egg reserve. How much does alcohol impact a man's sperm quality when trying to conceive naturally? Again, we have most of the data on all these lifestyle factors is in IVF because you can control for all the other variables. Whereas a natural conception is very difficult to control for different lifestyle variables. What we do know is excessive alcohol intake does reduce IVF success rates. Logically, I would think that if it affects IVF success rates, it affects natural conception as well. It doesn't have the same extent of impact that smoking does, but yes, there is a degree of impact. Yes. Endometrium too thin. Again, endometrium, it is not just the thickness, it is how it appears under an ultrasound, how the pattern of the endometrium looks. These are different factors we take into account when discussing about the endometrium. And we also need to balance cancelling versus restarting, and obviously the implications that has in both of time, stress, and so forth, versus going ahead with the embryo transfer. And it is always if it's generally the endometrium is less than 6 or 5 millimeter, generally if it's less than 6 millimeter, we would advise caution. But successful pregnancies have been reported even when the endometrium is thinner than that. And if we think in a different approach, there is a condition in there's a type of implantation in pregnancy which results in a pregnancy complication called ectopic pregnancy, where the embryo implants in the fallopian tube, and obviously in a fallopian tube there is no endometrium. So it is not an absolute requirement for the embryo to implant that you need to have an endometrium, but obviously a thicker endometrium is better for the chances of embryo implantation. Can a lighter period indicate lighter uterus lining or getting close to menopause? It can be completely innocuous, but it can also indicate either of these aspects, which is why, in addition to a medical history, we rely on these investigations. So history and investigations are two parts of a jigsaw puzzle. You just have one and not the other. It is challenging to find out the exact diagnosis. So we need the full investigation profile in order to say what the reason for that is. Oh, you've been asked about the duration of period. I don't think we can, as I said before, I don't think we can directly link a duration or lightness of the period to fertility on its own. That's difficult without the investigations. But yes, that's why we don't just rely on investigations. We take a full medical history. So it's a combination of medical history and investigations. Thank you, everyone, for all of your questions, and thank you for being with us till the end. And once again, sorry about the delay in starting. I do apologize, and I hope you found this session helpful, and do feel free to look on our website. It has a wealth of information, and obviously we look forward to supporting you with fertility treatment should you choose Care Fertility, and I sincerely hope you do. All the best. Thank you.